Welcome. Thank you for being here. Our first presentation for today will be Orthodontics, Cosmetic Functional Oral Health by Dr. Douglas Wolff. So let's give him a little welcome.
Okay, thank you. A little awkward to be using the microphone with such a small group here, but nonetheless, we'll just do it for all of those watching. So I'm Dr. Doug Wolff, a general dentist with Smile Orthodontics. And when we started at Smile Orthodontics in 2017, we had a small team. There was, I think, 4 of us, and we were doing one of our first interviews for a new dental assistant position. And we were seeing patients that were on public assistance and alongside fee-for-service patients. And this dental assistant said, she said, well, the reason that I agreed to come to this interview is, she said, because I saw you had some diversity on your team. And she said, before I go to healthcare visits, she says, I like to look on the company's website and just see if there are people that look like me and if I will feel comfortable going there. So we ended up hiring her, and we then, going forward, made a very concerted effort to hire a diverse team that would reflect the communities that we serve. So right now we have over 100 team members, and we have over 20 languages spoken on our team. That's Somali, Spanish, Hmong, Karen, among others. And most recently, too, we have a woman who's a Ukrainian refugee. So when we have patients that need communication in Russian or Ukrainian, she handles that for us. So we've grown significantly since 2017. And here's some of our team right here. And what we also did for our leadership team is we set out a mission, which we said we want to create a lifetime of confidence. And that is easy to see for our patients, where we're creating beautiful smiles for them. But also that is for our partners that we work with, that's for our external partners, and that's just also the communities that we serve. And then the ways that we do that are the values that we live every day. And so we want to demonstrate respect that brings people closer because we serve diverse groups of people and we have a diverse team. When we honor and respect those differences, that just makes us stronger as an organization. We want to serve in a way that exceeds our patients' expectations, our external partners' expectations. I know we have several of our external referring partners here, and we hope that when we deliver care for our patients, we have over 1,000 5-star Google reviews, that our patients get great treatment, they get great treatment results, and then our external partners also feel like we're taking care of their patients really well. And then we're also just in practice, and so we want to just improve a little bit every day. We have development plans for all of our partners, and we are just trying to get better as an organization every day. And I think just participating here, there are already ways that we can see that we can help. And so things that are unique to Smile Orthodontics, we have a commitment to underserved. We are one of the only orthodontic providers that accepts, is a critical access dental provider. We also have a commitment to our referring partners that see underserved patients. It's difficult enough for patients to get just general dental visits, but now we go to specialty care, and it's even more difficult. We have a team approach to care, which is a little bit different in that we have 4 orthodontic specialists, 4 general dentists, we have licensed dental assistants, and then we have unlicensed partners, and all of them are working together to carry out patient care. It's not just the doctor who's doing everything and seeing everything. It's a whole team approach to care. And then one of the ways that we do that clinically is that we have all digital treatment plans. So a lot of times the orthodontic plans would be in the orthodontist's head, and the clinicians would have to wait for the orthodontist to come over and tell them what to do. Well, because all of our plans are digital, the team is able to know what the plan is, and it just helps us when patients want to go to different locations for different reasons. Their care can continue, and we're currently the largest provider in the country of SureSmile, which is a custom robotically bent arch wires for our patients. So instead of that fine detailing where the orthodontist is bending the wire individually, we do the plan digitally, and then a robot in Florida bends the wires, and then each patient gets a custom treatment plan. And then in 2022, our leadership team set out a 10-year vision, because we know that at that time we were having patients come visit us from all over the state. So we said what we should do is be within a 15-minute drive for our metro area patients, and then a 30-minute drive for our rural patients, because we have people coming from St. Cloud, we have people coming from Rochester, and just even in the metro, if the child has an appointment, the parent has to leave work, go to school, pick up the kid, bring them to school, bring them to the appointment, bring the kid back to school, and go back to work. That's difficult in the Twin Cities, and it just gets even more, exponentially difficult when you go outstate Minnesota. So at that time, I think we were in Stillwater, Maplewood, and Minneapolis, and we needed to get closer to our patient base. So to that end, we are now in St. Cloud and Rochester, and a few other locations around the metro area. A couple of our points of contact, Marlene Vega and Famo Aiden are here today. If anyone would like to reach out, their contact information is here. And so when to refer patients for an orthodontic evaluation, so that's a common question. It can be any time that the provider is just kind of wondering what to do. I will fielded a call yesterday from a dentist who wanted to know about molar substitution, where a 11-year-old or a 10 or 11-year-old had a bombed out first molars, and he was wondering about could he do molar substitution, take out the first molar and allow the third molars to replace them. And there are lots of things that the providers are thinking about. How do we best treat kids and anticipate problems? And so we will see kids kind of as young as 7 or 8, but really most of the time we're not doing a lot of treatment at that time. We're trying to, if we can, instead of doing phase 1 treatment, we're trying to minimize the number of visits for moms and dads and kids while still providing the best outcome. So sometimes you can do some extractions to help guide teeth in and recommend that to the general dentist. We're doing right now, it's about 3% of our patients actually will do a phase 1 treatment. Whereas I think you'd see in the general population, other orthodontic practices want to kind of get kids into the system. But really the only times we're doing a phase 1 treatment, these are the guidelines that our doctors have set forth, is if there's damage to the tissue, damage to the enamel, or kids might have impacted incisors, or if there's a severe transverse discrepancy where the top jaw is significantly smaller than the lower jaw, or we will do some for the elective psychosocial reasons, but we want mom and dad to know that if you're going to do orthodontics for your 8 or 9-year-old, a lot of times those are elective, that's elective treatment and not necessarily required. But per the state guidelines, if there's a medical necessity like tissue damage or enamel damage, then the services might be covered. And so this would be a common something where we would have a child referred in and he has an anterior crossbite, but we also want to just wait until all 8 of the incisors are in before we start making treatment recommendations, because the dentist might be getting a little excited that there's a tooth and crossbite, and mom or dad might be getting a little bit excited, but we do need to wait, because for this young man, we said, okay, we'll wait until 7 and 10 come in, and then we'll decide on treatment. So you have to come back in 6 months. So when he comes back in 6 months, tooth number 10 was erupting and pushed 9 forward out of crossbite. So we didn't do anything, and this started to look better in 6 months. So we're just going to see him back one more time in another year, and now he's looking just fine a year later. And so we're going to see him another year later, and he's looking great. He might not need orthodontic treatment. So sometimes the best thing to do is nothing. We're going to save mom and dad money. We are going to save the kid trips to the office, and we don't want to introduce any iatrogenic problems by doing treatment that's not necessary. Because a lot of times, studies have shown that there is not necessarily a benefit. Some, especially these skeletal benefits for a severe class 2 overbite or underbite, those differences, you might make some difference in phase 1, but in the end, a kid has a certain amount of growth. I was going to be 6'4", whether my parents kind of tried to hold me down or not. That growth is just in there, and so there isn't a way to modify a child's growth. And so I think this is just an interesting study to see that when you have the combined phases, just the number of appointments increase. But I think some providers are worried about losing young kids in their practice if they don't offer some sort of treatment to those 8 or 9-year-olds. And I would tell patients all the time, sometimes our job is just to reassure mom and dad that your kid will be fine. You can walk into any 8 or 9-year-old birthday party and the teeth are just a hot mess going all over the place. And if you could just kind of sit tight, sometimes those things will just work themselves out and can be done in one comprehensive phase. But here's something, very similar case, but now this child already has 7, 8, 9, 10 in. This crossbite is deep, and tooth number 24 is losing some tissue attachment. So we're just going to do a quick phase 1 treatment where we're just going to do upper braces only, open his bite up, and get over that crossbite, and then just leave him be. And so this is just a quick 6-month treatment. We could make it so that tooth number 24 is protected again, and we will just do our normal 1-year recall and follow him to what I would say is age-appropriate orthodontics. And for boys, usually that's 12 to 14, and girls, that's 11 to 13. And then, why are people seeking orthodontics? Is it functional? Is it cosmetic? The state of Minnesota does have guidelines set forth from the American Association of Orthodontics, and there's specific criteria kids need to meet in order to qualify for treatment. And those things are functional, but really most of the times the people seeking orthodontic treatment, they're not there because of the open bite, the cross bite, the crowding. They want their teeth to look better. They don't feel good about how they look. And there certainly is a functional and maybe a long-term component to it, but functional reasons might look something like this. This young man who came to our Minneapolis location, so he can chew. He's gotten into young adulthood, but he has a skeletal discrepancy that's causing this anterior crossbite. So he's going to qualify for orthodontic care under the state's guidelines. He's in full anterior crossbite, but this is a really complex orthodontic and surgical case. So what we're going to need to do is not only just braces, but we're also going to work with the University of Minnesota and do jaw surgery for him, upper and lower jaw surgery. But this is the kind of case where a lot of other practices say this is too much work on the degree of difficulty scale. This is, most of these cases are an 11 out of 10 on the 1 to 10 difficulty scale. This young man, same thing. He can function, but he's meeting the criteria because he has an anterior open bite, and same thing. This is a skeletal problem, and he knows his teeth doesn't look quite right. He's not exactly sure why, but this is a orthodontic problem, but also a skeletal problem. And if you look, he has a really long lower face height, so it's a prominent lower jaw. So these, yes.
The previous case, is that because he wasn't referred early enough? Is that because they didn't go, like, you say he's a young adult?
He's, I think we saw him, he was 19 when we first saw him.
So that was happening all that time. So my question to you is, would
Anything be different done?
Yeah, did he have that jaw surgery when he was younger?
The jaw surgery you can't have until you're an adult. So had he come earlier, one of the things that sometimes people might try would be what's called a reverse face mask. So when he's really young, put a face mask on and try to pull his lower jaw forward. It's really challenging to do stuff like that for kids, and that's kind of the equivalent of trying to stretch a young kid out because you think that they're going to be a little shorter and you want them to be taller. And so you say, I'm going to kind of put you on the rack and try to stretch you out. So for someone like this, it's also incumbent on us to know when he's a teenager, we have to just say, we're going to just reassure you that when you get to age 18, we can help you out. But until then, this is a skeletal problem, and you have to wait till he's done growing before you can correct the skeletal discrepancy. And it's the same thing with this young man as well. If you look at his jawline, he just has a really long jawline. And so it's the upper jaw is larger than the lower jaw is larger than the upper jaw. And those discrepancies can't be taken care of until they're 18. And I think he was 17 when he started. And so that way we're kind of, it's about a year of treatment. He does the surgery at age 18, and then he's done by 19. And then this is really the other part. People are thinking, it's cosmetic reasons that people really come to us, and it's psychosocial. It's the patient's own psychology, kind of how they see themselves in the world, and then also, the hard part is how others perceive the patient. And so we have all the time parents come in and say, my kid is extremely self-conscious, they're bullied for their appearance, other kids are making fun of them. And so these reasons that seem cosmetic are really psychosocial reasons in young adulthood too. And so kids aren't thinking about a malocclusion. It's not the class 2 or class 3, but this self-esteem is a salient part of their oral health and related quality of life in kids that are seeking orthodontic treatment. And that's a lot of time, parents want what's best for their kids. They want their kids to be successful. They want to set them up on the right path. So to that end, this young gal, she, can't function on her front teeth. She's got severe crowding. So she meets the criteria because of her anterior open bite. She's coming to us. This was, we started her, I think, in 2021. She's coming to us from Worthington, Minnesota. She came to see me in Stillwater. That's a 3.5-hour drive that she and her dad made to come see us. Because other places might see her, but they weren't going to accept her potential benefit. She would just have to pay out of pocket some kind of payment plan. However, Dad was able to make this worth his while because he was also bringing her sister. So both of these two gals would pile in the car in the morning, Worthington, have an appointment kind of around the noon hour, get their orthodontic appointment done. They had to come up 14 times. We had to coordinate with their dentist down in Worthington to have extractions done. And, that is a big commitment. But for the dad, he says, I want my daughters to have this. I know how important this is to them. And so I'm going to make this happen. And I think this is the challenge, is that we know that there's we'll call this Instagram or social media society, there are perceptions of others about your attractiveness, but it even goes to intelligence and social desirability. There's a beauty bias that this dad says, I don't want my two daughters kind of handicapped by this for their lifetime, so I'm going to make this happen. I'm going to drive up to Stillwater and get orthodontic treatment done. And then this young lady, just in the cities here, she's from Oakdale, but if you were to leave this untreated, there's, her incisors are not meant to bear the brunt of her occlusion. So in a crossbite like this, if left untreated, what's going to happen is just over her lifetime, she's going to chip 7, 8, 9, 10, and 23 through 25, because those those incisors are not meant to bear the kind of chewing force over her lifetime. And sure, that's what we think, that's what us dentists are concerned about. And she just says, like, I want my teeth straighter. Kids are making fun of me at school. So that smile just ends up being that first impression, and it has these attributes where we as a society start transferring judgments about somebody's intelligence or even competence based on that first impression. We all know that you see somebody with a telegenic, beautiful smile, you think, I trust that person, or I like that person. And so that is the challenge for some of these kids. But sometimes for us at Smile Orthodontics, it's actually like the patient's first entry point into the oral healthcare system. And so it's not just kids, it's sometimes adults that come see us and say, hey, I want braces, I want my teeth to look better. Well, for this man who came to see us in Rochester, he has significant periodontal disease. He has missing teeth in the posterior. He has decayed root tips in the posterior. He has other active decay. A reasonable goal for him is just to keep his teeth for the rest of his lifetime. So now we're going to work with we've told our doctors, like, we're sometimes a patient's entry point into the oral healthcare system. So come see us. I know you want braces, but you're not a candidate. What you're a candidate to do is go to see one of our referring partners, and then we work with them to get them in and set the patient's expectation that you're going to go to your general dentist and get a dental home and get your teeth cleaned and get your gum disease treated and get these infected teeth out and just try to keep the rest of these teeth for your lifetime. That's a reasonable goal for this gentleman. Also, we will see patients that come to us from all over the world. We're a cosmopolitan global city and a region, and kids will come and they will have had braces on from some other country, and they're effectively, other places won't work on this. Hard for the general dentist to see them, and they'll say, I want to continue with my orthodontic treatment that I started in Venezuela or wherever it is. Well, these poor kids are in orthodontic jail. So what we will do is we will just take off their braces at no charge, and then we'll refer them to their general dentist to take off the braces at no charge, refer them to the general dentist, and just get them restarted so that they get a dental home and get squared away, because otherwise they're just stuck. the general dentists don't have the time or all the instruments to take off 28 brackets, and so that's a service that we can provide for our referring partners. So like this gal was having braces done in Egypt, and they were new to the country, and Dad said, I'd like to continue her orthodontic care. Well, she's got some inappropriate treatment mechanics going on here. We've got her premolars kind of being pulled out of the arches, and so we're not going to continue treatment. She needs to first get these braces off and go see a general dentist. So that's what we're going to do. We just see them, get the braces off, and get them to a general dentist. And once they receive general dentist clearance, then we can restart treatment. And patients all the time say that they were just in, or they're up to date on their oral hygiene or restorative, and so it's up to us to just make sure that we clear with all their general dentists before we're starting something that's somewhat more elective. And so just a few smile transformations based on some of those patients we saw earlier. So this is our Minneapolis patient. This is 2-jaw surgery, maxillary advancement, and a mandibular setback. He doesn't even look like the same guy. And much as we do all of our cases digitally, where we work them up and we're able to show the patient where they're going to go, when we're working with the oral surgeons, they are also doing the same thing so patients can have a visual of what they're going to look like after the orthodontic treatment, and the oral surgery. And then this young man, so now his teeth touch, he's happy about that. We can see the difference in his lower face height is significantly different. And when we got his braces off after his surgery, everyone is oohing and ahhing about how handsome he was, and he left just beaming as our staff just kind of lavished the compliments on him, how handsome he was. Here is our one of the sisters from Worthington. So this is 4 premolars extracted and 14 visits in about 20 months of coming up to the Twin Cities to get treatment. And here is her sister. She, same thing, 4 premolars out, 14 visits. And they are tickled. Dad is happy, and it just neat to be able to provide that service for them. And then this one is just kind of a favorite of mine, where you can look and see, sure, we've corrected the crossbite. We've got perfect class 1 occlusion. The midlines are on. I mean, so dentally, that part feels like that's great. But as soon as you go out from there, you see the lip gloss. You see she's smiling so big now that her dimples are showing. She's got the earrings on. She's got her hair all done up. And I know we've got the little blue dots to anonymize her, but at the same time, like, if you could see the twinkle in her eye, I mean, she is just tickled. And when we think about a lifetime of confidence, that's what this young gal now has. So there's my contact information. What questions do you all have? Yes?
Monitoring, you might be missing those other elements. It just hadn't occurred to me. From a public health perspective, I was like, this could be really cool. This could be really life-changing for our, for instance, in Greater Minnesota, where we have very little access. But at the same time, we could be missing some important things.
Yeah, for us, it's trying to catch those important things on the front end. Most of the time, when people come to us, they say that they were, we make sure, have you been to your general dentist recently? And they said, yeah, I was just in. And they're a once every 5-year patient. And so they have to have been in within 1 year, and all of their restorative has to be complete. Because if we leave it where they just have one or two things left to go, as soon as they get the braces, they are not going to do those one or two restorations. They have to have it all done and be kind of in good, in theory, like perfect, stable oral health before you go on to the orthodontic part. Yeah. Yeah.
I'm the pediatrician from next door, and it has happened twice in the 30-year career. But I've had patients who had braces placed by an orthodontist, and then their insurance changed, and then no one else would continue their treatment, and they were like, no, we're going to take them off. And medical assistants in the state of Minnesota only has a lifetime benefit one time, and they were like, well, we're just going to take them off. Is that, it's happened 2 times, and the most recent time was in this past year. One was probably 10 years ago, and I was just very confused by that. So is that a thing? Like if they have insurance from the state that covers the placing of the braces, and then their insurance changes, no one's going to see them anymore?
Oh, it happens really with patients on all insurances because insurances are set up most of the time to pay over, 12 to 24 months. So what ends up happening is, and we tell our patients they have to sign a kind of non-covered service waiver because they need to keep up with their insurance. But you could be with an employer-based insurance, and plenty of people do this end of the year. They'll think, oh, I'm going to get this done, and I know I'm leaving this job, or I know next year I'll drop the orthodontic benefit. Well, that benefit maybe pays $500 quarterly. And so people are thinking that the payments all happen up front. The payments happen over time, and that's to protect the payer. That's whether that's a Delta Dental or whether that's a parent that's paying for treatment. That the services haven't been all delivered, so the payment is spread out. So it is something that we have to kind of work through. And sometimes if patients are not eligible for a month, they will make a payment. Sometimes if they go off, they'll just say, I want to discontinue treatment. And people sometimes will discontinue treatment because they can't make it to their appointments. Moms or dads can't get them there. And so we'll just sometimes dismiss patients because they just have failed too many times. And we offer to take the braces off and say, we'll restart when it's a better time for you. And they don't even sometimes not show up for that.
Just a quick question.
Yeah.
Is 14 visits, you mentioned that numbers guy a couple different times. Is that a typical number of visits?
We're at about 16 visits right now for our comprehensive treatment. I mean, I just had to really kind of focus in on these 2 girls because obviously our extraction cases take a little longer, but they just had to, we spaced out their visits a little longer than normal. So longer intervals to get the number of visits down for them.
So yeah, it seems like, in Appletree's model where we have the hub and the spoke, we use the term hidden copayment, I do, for all those travel costs that you enumerated from where the game was really dramatic. But even in the metro, it's the same thing. A parent needs to have public or private transportation, and you need daycare. There's all this other stuff for every visit. It's not covered by Medicaid, right? So that's why I use the term hidden copayment. And if you add up, well, what does it really cost somebody who's low income for all of it? It's often more than what Medicaid actually pays the dentist for whatever the service is. So, we really try to think about how do you use remote monitoring and telehealth and things like that to minimize how many of those hidden copayment events there are, and make sure that when they do pay that huge hidden copayment, that they're getting the optimal, complete treatment, at that visit rather than a minimal experience at that particular visit. So I'd love to talk with you more about that, but it seems like being able to distribute out to minimize those hidden copayment costs somehow, but getting close to them is the strategy you mentioned, so having more offices or whatever. But maybe some combination of more mobile and more telehealth would close that particular gap, because that seems like it's a big barrier for a lot of people.
Yes. Mhm.
Cool, that's
Thank
really
you.
impressive. I don't know if you want to talk a little bit more about critical access and the fact that you're a critical access provider. I think that,
Sure. I mean, so in order to qualify as a critical access provider, you have to see at least 50% of your patients on public assistance. And I'd say our locations range from 50% to 80% public assistance patients. And so, you know, in our facilities, I'd liken it to just going to Target or Costco. You know, our facilities are really modern looking, really clean looking, kind of Apple Store-esque. And it makes it so that, you know, people don't feel like I have any different insurance than anybody else. We kind of take care of that up front, and then everybody just feels like, oh, this is just a, you're just receiving, much like you go to the hospital or the clinic, you're sitting alongside of just everybody. A lot of orthodontic places, it might be smoothies and warm cookies and extra TLC type of things for, you know, or rewards things so your kids can, if they brush their teeth, they can, you know, win prizes and this kind of thing. And so, you know, we're trying to make it healthcare and oral healthcare in a way that feels really comfortable and clean and modern for everybody, so that everybody just feels like, hey, this just a normal place where you go to get a perfect smile.
How many are there of the critical access in the state?
There are orthodontic providers, maybe 2 or others, but most of them are just, you know, they'll do it 2 or 3. I think a lot of times they'll do like a location. So they might have a few locations. They'll say, hey, we'll send all of our public assistance patients. You go to this location, and they kind of, that's a stripped down, bare bones location. Or sometimes people might flex in and out of it. Like they'll take some public assistance patients to round out their schedule, but it's not something they're committed to. And as soon as they can, you know, build up their schedule, then they, you know, then those patients are the first to go.
I just want to shout you guys out. I think your mission-oriented philosophy is incredible, and your facilities are beautiful. Yeah, thank you guys.
Yeah. Thank you.